Functions of sesamoid bone act as puller for muscle contraction, alter the direction of the pull of the muscle, minimize the friction of tendon against the bone to prevent its attrition. Characteristics of sesamoid bones develop in the tendon of the muscle are devoid of periosteum, ossify after birth, usually by multiple centers. Lack harvestium system. Note well, patella is the largest sesamoid bone in the body and the cartilage covering its articular surface is the thickest articular cartilage in the body. Sesamoid bones are not classified as true bones as they are not covered by periosteum. Accessory bones. These are bones that are not generally present in the human body. If present, they do not cause any harm. Sometimes clinicians Sometimes clinicians confuse it with a fractured bone. Accessory bones may be formed due to appearance of extra ossification centers in skull sutures. For example, sutural or Ormanian bones, non-fusing of an epiphysis. The examples are as os etrigonium, the posterior tubercle of the talus that fails to fuse with the rest of the bone, os vesalinum, the osteoid process of the fifth metatarsal of the failed to fuse with the first of the bone, patella cubiti. Occasionally, the center of ossification for the olecranon process of ulna fails to fuse to the proximal end of the shaft. For example, heterotopic bones sometimes formed in soft tissue where they are not normally found. For example, writer's bone in the tendon of adductor longus muscle of the thigh. B. Structural classification macroscopically. For example, as seen on naked eye examination of a section of a long flat bone, the architecture of bone may be compact, dense, or cell cancellous, spongy. Most bones of the body have a basic structure of an outer region of compact bone and inner region of spongy cancellous bone. For example, in longer bones, the shaft consists of compact bone forming a cylinder that surrounds a central cavity called medullary cavity. The ends of longer bones consist of cancellous bone surrounding by a thin layer of compact bone. In longer bones, the shaft consists of compact bones forming a cylinder that surrounds a central cavity called medullary cavity. The ends of long bones consist of cancellous bone surrounded by a thin layer of compact bone. In flat bones, the skull, the cancellous bone is sandwiched between the plates of compact bone. The spongy part is called dipple, and outer and inner plate of the compact bone are called inner and outer tables. Note well, all the bones of the body consist of both compact and spongy bones except inferior nasal concha, which consists of only a spongy bone. Compact dense bone. The structure of compact bone is dense, ivory like, with no visible space or naked eye examination. The compact bone consists of a lamellae of cartilage sheaths and Harvesian system or osteons. Lamellae. The compact bone consists of three types of bony lamellae. Concentric lamellae which surround the Harvesian canal. Interstitial lamellae lie between the osteon. The interstitial lamellae are remnants of old outer circumferential lamellae or old Hervesian systems. Circumferential lamellae, which are flat parts that extend around the bone. Hervesian system, osteon. Each Hervesian system consists of a Hervesian canal or central canal surrounded by concentric lamellae of bone. Hervesian canal runs parallel to the long axis of the bone and contains blood vessels, nerves, and loose connective tissue. The concentric lamellae forged 20 number from rings around Hervesian canal. The osteocytes are located between the lamellar rings is lacunae. The lacunae communicate with one another in between and cross the lamellae and with the central canal by numerous radiating canaliculi. Hervesian canals are lined by endosteum and communicate with each other, with the medullary cavity and with the surface of the bone by numerous Volkmann's canals. The Volkmann's canals run perpendicular to the long axis of the bone. The blood vessels form the periosteum or endosteum enter the bone through Volkmann's canals. The Hervesian canals receive blood vessels from Volkmann's canals. Figure 6.4 Structure of compact bone A. Hervesian system and lamellae B. And osteon C. Periosteum outer circumferential lamellae of compact bone. The osteocytes receive nutrients and eliminate waste products through the canal system. Cancellous spongy bone. The cancellous bone is a meshwork of bony spicules. It consists of interconnecting rods and plates of bones called trabeculae, enclosing large spaces filled with red bone marrow. The tubercle consists of superimposed lamellae and do not form Hervesian system because they get nutrition from the blood vessels of tissue around them. Have a layer of osteoblast on their surface. Are oriented along the line of stress. The difference between the compact and spongy bone are given at table 6.2. Difference between compact and spongy bone. Density like an ivory, porous like a sponge. Hervesian system present, absent. Arrangement of bony lamellae, regular, irregular. Location in the bone, outer region, inner region. Bone marrow, absent, present. Amount in the body by body weight, 75%, 25%. Wolff's law, trajectory theory of Wolff, 1892. According to this law, the bone formation osteogenesis is directly proportional to stress and strain. The tensile force favors bone formation, whereas compressive force favors bone resorption. This theory, however, no longer holds good because now it is noticed that both tensile and compressive force can stimulate bone formation in procreate conditions. The architecture of cancellous bone is often interpreted in terms of Wolff's law. Thus, the arrangement of the bone lamellae is governed by the lines of maximal stress. Pressure lamellae are arranged parallel to the line of weight transmission. Tension lamellae are arranged in the right angles to the pressure lamellae. Figure 6.5 Diagrammatic sagittal section of the upper and the femur showing pressure and tension lamellae and sursal formally. Note well, the compact arrangement of pressure lamellae from bony buttress to provide additional support. For example, calcar formal clinical correlation. The tubercle are oriented along the line of stress within a bone. If the direction of weight bearing stress is changed slightly, for example, because of a fracture that heals improperly, the tubercle pattern realigns with new lines of stress. For this reason, patient often complains of pain at the structure site in later life. Often complains with pain at the structure site in later life. Microscopically, bones are two types, woven and lamellar. This classification is based on the manner in which the different components of the matrix are arranged. Woven bone. The collagen fascicles are bone crystals within a woven bone are arranged normally, formed a network resembling the wrap and the weft of a woven fabric, and hence the name woven bone. The examples of woven bone are young fetal bones, most immature bones, cancellous at fracture repair sites, lamellar bone. In lamellar bone, the mineralized matrix is arranged in layers, lamellae. The lemurs are arranged into different patterns in number of concentric cylindral units. Hervesian system, for example, compact bone. In number of branching and anastomosing curved plates, for example, spongy bone. Note well, all the adult bones are lamellar bones. See development classification. According to the process of bone development ossification, the bones are of the following three types: membrane bone, developed by membranous ossification; cartilage bone, developed by membrane bone, developed by membranous ossification; cartilage bone, developed by endochondral ossification; cartilaginous bone, developed by both membranous and endochondral ossification. For details, see development of bone on page 77. The examples of bone according to their development are enumerated on table 6.3. Gross structure of a typical long bone. A typical long bone consists of three pairs: shaft, a body, and two or three ends. The shaft is an elongated part between the two expanded ends. It is made of outer thick shell of compact bone cortex enclosing a cavity called medullary cavity. A typical long bone consists of three parts: a shaft or a body and two ends. The shaft is an elongated part between the two expanded ends. It is made of an outer thick shell of compact bone cortex enclosing a cavity called medullary cavity, thus providing maximum strength with minimal material and weight. The medullary cavity is filled with yellow bone marrow. Remember that at birth it is filled with red bone marrow and it is involved in active homeopoiesis. Remember at birth is red bone marrow. The end of knobby, expanded, and largely made out of cancellous bone covered by a thin shell of compact bone. The end of long bone are covered by an articular hyaline cartilage and take part in the formation of joints. Examples of bone according to their development. Types of bone. Examples: membranous bones of cranial vault, facial bones; cartilaginous bones of limbs, bones of base of skull, bones of vertebral column, vertebrae, bones of thoracic cage, ribs, sternum; membranocartilaginous mandible, clavicle, capsipetal bone, temporal sphenoid bone. Gross structure of a typical long bone. The insets shown details of a spongy above and compact below bones, periosteum and endosteum. The outer surface of all the bones are covered by thick fibrous membrane called periosteum, whereas the inner surface are lined by a thin fibrous membrane called endosteum. Both periosteum and endosteum contain osteoprogenitor cells. The outer surface of all the bones are covered by thick fibrous membrane called periosteum, whereas their inner surface are lined by the thin fibrous membrane called endosteum. Both periosteum and endosteum contain osteoprogenitor cells, osteoblasts and osteoclasts, which are essential for formation, remodeling, and repair of bone. The periosteum is a thick fibrous membrane covering the entire surface of bone except the area covered by articular cartilage. At the articular margin, the periosteum is continuous with the joint capsule. It is made out of two layers: outer dense fibrous layer, inner cellular layer, which is osteogenic in nature. The periosteum is united to the underlying bone by eccentric collagen fibers. The sharpest fibers, these are coarse collagenous fibers from inner layer which extends inwards to penetrate the bone matrix, outer cortical bone tissue, like spikes of shoes, this bolting the periosteum to the bone. Functions of periosteum. Periosteum and protects and maintains the shape of the bone, nourishes the outer part of, provides attachment to ligaments, tendons, muscle, and intramuscular septa, provides regenerative capability to the bone. The endosteum is cellular membrane that lines the medullary cavity to the shaft. The osteoblast and osteoprogenitor cells within the endosteum play an important role in the bone remodeling and repair. Nutrient foramen is usually present near the middle of shaft for the entry of nutrient artery. Clinical correlation. The periosteum is important in the repair of fractures. It has unique capability of forming new bone. Hence, bone stripped of its periosteum will not survive. The periosteum is very sensitive to pain, particularly to tearing and tension. Therefore, drilling into the bone without anesthesia is very painful. For the same reason, during intramuscular injection, the needle penetrates periosteum. Severe pain is felt by the patient. Bone marrow. The bone marrow is a soft, loose vascular tissue consisting of delicate network of reticular fibers and various types of cells. It is the main site of homeopoiesis. It is the main site of homeopoiesis. It is present in the medullary cavity of long bones and in the cavity of the spongy bone. Types of bone marrow. Two types of bone marrow are described according to their appearance on gross examination: red bone marrow, yellow bone marrow. Red bone marrow. It is vascular and appears red in color due to the presence of red blood cells. It consists of network of fine reticular fibers containing blood forming cells, showing the stages of development: immature nucleated and mature non-nucleated red blood cells, myeloblast, myelocytes, granulocytes, megakaryocytes, etc. At birth, it is present in all the bones at all sites and in an important site of homeopoiesis. But as the age advantages, the marrow The marrow in the medullary cavity of long bones is gradually replaced by yellow marrow. Hence, in the adults, the red bone marrow is found cancellous bone. The sites are as follows: end of long bone, sternum, ribs, skull bones, iliac crest and hip bones, vertebrae. Clinical correlation. Bone marrow aspiration. It is often performed by the clinicians for diagnostic purpose. The sites commonly used for bone marrow aspiration are sternum, anterior and posterior iliac spines of hip bones, ribs, lumbar spinous process, and upper end of tibia. In the adult, the common sites of bone marrow aspiration are manubrium of sternum and spinous process of lumbar vertebrae. In the children, the common site of bone marrow aspirations are iliac crest and hip bones. Sites of red bone marrow. Bone marrow aspiration. It is often performed by the clinicians for diagnostic purpose. The sites commonly used for bone marrow aspiration are sternum, anterior and posterior iliac spines of the hip bones, ribs, lumbar spinous process, and upper end of tibia. In the adult, the common site of bone marrow aspiration are manubrium of sternum and spinous process of lumbar vertebrae. In the children, the common sites of the bone marrow aspirations are iliac crest of the hip bones. Yellow bone marrow. It mainly consists of adipose tissue. However, few homeopoietic elements may be found in it. Under certain conditions such as severe bleeding or hypoxia, yellow bone marrow converts black into red. Yellow bone marrow converts back into red bone marrow, such as severe bleeding or hypoxia. Note well, in old age, sometimes the red bone marrow in the skull bones degenerate to produce jelly-like material. Galateous mass is known as galateous marrow. Parts of growing young long bone. A typical long bone develops from a preformed model of hyaline cartilage in three parts: two ends and an intervening shaft. The two ends are formed by secondary centers of ossification, and the shaft is formed by primary centers of ossification. Before the ossification is complete, the following parts can be defined in the young bone: epiphysis, epiphyseal plates, metaphysis, diaphysis. Epiphysis. These are ends of long bones which ossify from secondary centers. Types of epiphysis. The epiphyses are of the following four types. Pressure epiphysis. It is covered by an articular cartilage and takes part in the transmission of body weight. For example, head of femur, humerus, lower end of radius, etc. Figure 6.9. Types of epiphysis: pressure and traction epiphysis, B and D, activistic epiphysis, aberrant epiphysis, traction epiphysis. It is produced by a pool of muscle or muscles, for example, greater and lesser trochanter of femur, greater and lesser trochanter of humerus, etc. It is always non-articular and provides attachment to the muscle or muscles. It always ossifies later than the pressure epiphysis. Atavistic epiphysis. It is an independent bone in lower mammals which in man gets fused to the nearest bone to receive nutrition from the host bone. It grows like a parasite. For example, coracoid process of a scapula, posterior tubercle of talus, which is known as osteogonum. Aberrant epiphysis. It is an epiphysis which appears at the head of first metacarpal. Remember, normally epiphysis appears at the base of first metacarpal bone. Epiphyseal plate. It is a plate of hyaline cartilage which intervenes between the epiphysis and diaphysis of a growing bone. The proliferation of cell in the epiphyseal cartilage is responsible for growth in length of the longer bone. For details, see page 85. After the fusion of epiphysis with diaphysis, the bone can no longer grow in length. The epiphyseal plate cartilage is nourished by both epiphyseal and metaphyseal arteries.
Does not grow by multiplication of the cell or by increase it is intercellular material, intestinal growth. Hence, its shape cannot be maintained. The bone grows by deposition of the new bone by osteoblast, or it ends and on its surface its random fashion. Therefore, to maintain its shape, the unwanted bone is removed by osteoclast. This process of bone removal is called the remodeling. Surface remodeling. As the bone grows in length, there occurs subperiosteal bone deposition in the shaft, while subperiosteal bone reabsorption occurs in conical region toward the end. Thus, diverging regions are strengthened to become the part of the shaft. Internal remodeling. As the bone grows in diameter by deposition of new layers of bone deep to periosteum, these deviating regions are straightened to become the part of the shaft. Internal remodeling. As the bone grows in diameter by deposition of the new layers of bone deep to periosteum, the periosteal bone become thicker and thicker, which is neither necessary nor desirable. Hence, as the bone is laid down outside the shaft, it is removed from inside by osteoblast. Consequently, the shaft grows in diameter, and at the same time, its wall does not become too thick. The osteoclast also removed the trabeculae in the center of the bone that were formed by the endocondylar ossification. This leads to the formation of marrow cavity. Remodeling of developing bone is done by the deposition of bone by osteoblast and selective absorption of bone by osteoclast. Clinical correlation. Paget disease. Normally, the bone is continuously removed and repaired, replaced by new bone throughout life. In Paget disease, osteo's deformance, which occurs in later life, there is uncontrolled osteoclast activity causing widespread bone deposition, which is followed by the hectic osteoblastic activity producing open bone osteoid that feels the erosion, but the repair stops at the osteoid stage. As a result, the healthy mature bone is gradually replaced by thick, bulky, weak osteoid bone. Consequently, in individuals suffering from Paget disease, the bones are thick and bent, especially the femora, tibia, and spine. The skull is enlarged and thick. The spine is blunt forward kyphosis. Factors affecting growth of bones. Nutritional factor. Vitamin A coordinates that activity of osteoblast and osteoclast. Deficiency of vitamin A slows down the activity of osteoclast. Consequently, the size of spinal and cranial foramina is reduced with eventual compression of nerve roots. On the other hand, the high concentration of vitamin A causes the rarefication and reabsorption of bone. Vitamin C is essential for the synthesis of organic intercellular matrix, collagenous fibers, and ground substance by osteoblast. The deficiency of vitamin A leads to defective development of growing ends of the bone. It also leads to rupture the capillaries, producing painful subperiosteal hematoma. Vitamin D is essential for the absorption of calcium and phosphate from intestine. Deficiency of vitamin D leads to defective generalized calcification of the osteoid tissue. As a result, children suffer from rickets characterized by the bowing of legs, novi, metastatial region, and adults suffer from the osteomalacia. Hormonal factors. The hormones play a very important role in bone growth. The hormone which is essential for proper development and growth of bone include pituitary hormones, thyroid hormones, parathyroid hormones and sex hormones. Their defective secretion can cause the number of skeletal defects. Genetic factors. The clinical condition chondrodystrophia fetalis occurs due to defective autosomal genetic inheritance. In this condition, the endochondral secretion fails to occur properly. Mechanical factors. Tensile force helps in bone formation, whereas the compressive force favor bone resorption. In practice, the orthopedic surgeon provides traction for quick healing of fracture. Cartilage. The cartilage is a specialized connective tissue which provides rigidity along with elasticity. Hence, it is found in those areas of the body where both rigidity and elasticity are required. It consists of chondrocyte embedded in a gel-like matrix. Physiologically, the cartilage tissue is older than bone tissue. Most of the bones is the later in life are performed in cartilage. The cartilage which are replaced by bones are called the temporary cartilage. Then those that persist throughout the life are called the permanent cartilage. Function of the cartilage. The following are the function of the cartilage. Provides rigidity and support to soft tissue. Provides smooth girdling surface for articulation. And envelop, developed and growth of long bones. Both bone and cartilage are specialized connective tissue, but the specific difference between the two is that its bone matrix is mineral. Where in cartilage it is not mineralized structure. The cartilage has all common feature of connective tissue, which include the following: cell, fiber, and ground substance. Cells of the cartilage are the following three types: chondrogenic cells, chondroblast, chondrocyte. Chondrogenic cell found the pericardium, where they undergo the mitosis and differentiate into chondroblast. Chondroblast, young cartilage cells occupying a small space laterally and may undergo the mitosis. Chondrocytes, mature cartilage cells which reside in lacunae. They from the isogenous cell cultures surrounded by the peritoneal matrix. Fiber cartilage has following two types of fibers. Type 1 collagen fibers is fibrocartilage. Type 2 collagen fibers in hyaline and elastic cartilage. ठीक है सर? Ground substance consists of the proteoglycans, glycoprotein, and water. Proteoglycan, especially chondroitin sulfate and keratin sulfate. Glycoprotein, chondronectin and chondrolacin, a calcium binding protein. Water, tissue fluid, contributes to 75% hydration of the ground substance, high degree of hydration. There is no mineral component in the ground substance of the cartilage because it is the cartilage grows by both apogeusial and interstitial method. Apostatial grows. In these layers of new cartilage are deposited at the surface beneath apostatial growth. In this layer of new cartilage are deposited at the surface beneath the pericardium. New cartilage is formed by the chondroblast derived from pericardium. By appositional growth, the cartilage increase in the এগুলো ঠিক জায়গায় রেখে দাও. Growth, it occurs due to increase in size, the number and existing cells, and by the increase in the amount of intercellular matrix. Due to the proliferation of the chondrocyte by the mitosis is the center of cartilaginous model. By intestinal growth, the cartilage increases in length. Adult cartilage grows, it repairs slowly after a severe injury. Characteristic feature of cartilage. The distinguishing feature of cartilage are as follows: is a avascular and reserves in its nutrition by diffusion through the ground substance from the nearest capillaries. Here the cartilage canals provide the nutrition of the deepest core of the cartilaginous mass. It has no lymphatics. It has no nerves, hence its incentive. It is surrounded by the pericardium. It grows by the appositional as well as by the intestinal methods of growth. When cartilage calcifies, chondrocytes die because they are derived of nutrition by diffusion. The articular cartilage and fibrocartilage divided of pericardium. Clinical correlation: cartilage graft. The cartilage has low antigenicity due to lack of lymphatics and isolation of the chondrocyte in separate lacunae within matrix. Hence, homogeneous transplantation of cartilage is possible without rejection. Cartilage repair. Damaged cartilage shows the limited repair regeneration, with defects being slowly filled with scar tissue instead of cartilage. Thus, repair of cartilage takes a long time because it is avascular. Types of cartilage. Cartilage are derived by the three types: hyaline cartilage, elastic cartilage, fibrocartilage. Hyaline cartilage appears brush while the transparent because it contains very fine collagen fibers having same refractive index as the ground substance. It is the most widely distributed cartilage in the body. All the long bones in the body are performed in hyaline cartilage. All the hyaline cartilage are covered by the pericardium except articular cartilage. Non-articular hyaline cartilage has tendency to calcify and to be replaced by bone. Elastic cartilage. It is made up of the numerous chondrocytes embedded in matrix containing rich network of yellow elastic fibers. The site of the distribution of the elastic cartilage include pinna of the ear and epiglottis. Fibrocartilage. It appears while and oblique due to the abundance of collagen fibers in it. The collagen fibers are arranged in bundle. The chondrocytes are few, small and scattered, singly or arranged in rows. It is formed at sites subject to great pressure like the intervertebral discs. The key histological feature are three types of cartilages are presented table. The distributed of the three types of cartilages in the bodies and enumerated in table. The hyaline cartilage, elastic cartilage, fibrocartilage. Color. Hyaline cartilage is glossy, bluish and transparent. Elastic cartilage yellowish. Fibrocartilage white and oblique. Pericardium present. Elastic cartilage present. Fibrocartilage absent. Chondrocyte present in large number, singly or in groups inside lacunae. Larger, more numerous and packed more closely inside lacunae as compared to hyaline cartilage. Few in number, scattered singly or arranged in rows. Matrix. Homogeneous, basophilic, collagen fibers, delicate and not viable. Rich in elastic fibers. Thick bundles are collagen fibers can parallel within matrix. Tendency to classify: common in later life, less common, absent. Site of hyaline, elastic and fibrocartilage. Hyaline cartilage, elastic cartilage, fibrocartilage. Articular cartilage of the most of the joints, pinna of the external intervertebral discs. Thyroid cartilage. তাহলে হাইলাইন কার্টিলেজের মধ্যে আমরা কী কী পাচ্ছি? আর্টিকুলার কার্টিলেজ অফ দি মোস্ট অফ দি জয়েন্টস, থাইরয়েড কার্টিলেজ, করয়েড কার্টিলেজ, লোয়ার পার্ট অফ দি এটিনয়েড কার্টিলেজ, ট্রাকিয়াল রিংস, কোস্টাল কার্টিলেজ, ব্রঙ্কিয়াল কার্টিলেজ, নেজাল কার্টিলেজ, সব হচ্ছে হাইলাইন। আর ইলাস্টিক কার্টিলেজ পিনা, এক্সটার্নাল এয়ার, এপিগ্লোটিস, cornicual cartilage, cuneiform cartilage, apex of the arynoid cartilage, auditory tubes, external auditory meatus, and fibrocartilage, intervertebral discs, interpubic discs, menisci of the knee joint, articular discs, and the temporomandibular and sternoclavicular or infero-radioulnar joint, articular cartilage of temporomandibular, sternoclavicular, and the acromioclavicular joints, glenoid labrum and the acetibular labrum, etc.
Golden facts to remember. Total number of bones in the body 206. Largest bone in the body femur. Smallest bone in the body stapes. Longest bone in the body femur. Smallest long bone in the body malleus. Most slender bone in the body fibula. Largest flat bone in the body hip bone. Largest sesamoid bone in the body patella. Most actively growing area of the long bone metaphysis. Most vascular area of the long bone metaphysis. Most commonly fractured bone in the body Clavicle in children adults. Radius in people over 50 years old. Clavicle. Largest nutrient artery in the body. Nutrient artery of tibia. Commonest site of osteomyelitis in long bone metaphysis. All the long bones of the body lie vertebral except clavicle, which lies horizontally. All the bones of the body are covered by periosteum except sesamoid bone of ear and ossicle. All the bones in the body are made out of both compact and spongy bone except inferior nasal concha. All the bones of the body from joints except hyoid bone. Commonest site of bone marrow aspiration, manubrium sternum in adults and iliac crest in children. Firstborn to ossify the body clavicle. First bone to ossify in the body clavicle. Commonest congenital anomaly due to defective anadroplasia dwarfism. Commonest congenital anomaly due to defective membrane ossification, cleidocarnial diastosis. Commonest congenital anomaly due to defective membranous ossification. Most common site of accessory bones, lamboid structure of skull. All the long bones in the body follow law of ossification except fibula. Most abundant cartilage in body, hyaline cartilage. Most durable cartilage in the body, fibrocartilage. Largest yellow elastic cartilage in the body, cartilage of ear auricle. Largest hyaline in cartilage in the body, thyroid cartilage of larynx. Cartilage of larynx. Part of growing long bones commonly involved in osteomyelitis is metaphysis. The scapula is an example of irregular bone. All the following bones are pneumatic except B. Mandible. Primary center of ossification appears in diaphysis. Primary center of ossification appears in diaphysis. The secondary center of ossification appears in epiphysis. In adults, the red bone marrow is found in all of the following sites except medullary cavity of long bones. In advanced ages, galateous bone marrow may be found in skull bones. All of the following bones ossify partly in membrane and partly in cartilage except parietal. The coracoid process of scapula is an example of atavistic epiphysis. All the coracoid process of scapula. All the following are examples of traction epiphysis except coracoid process and scapula. All the following bones are examples of sesamoid bone except pisiform. All of the following statements are true about hyaline cartilage except that it has abundant elastic fiber in its matrix. All of the following are examples of white fibrocartilage except cartilage of pinna and the ear. All of the following statements are true regarding elastic cartilage except that it is adapted to withstand tension and compression. All statements are true regarding hyaline cartilage except that it forms menisci knee joint. Chapter 7 Joints. Learning objectives. After studying the chapter, the student should be able to classify the joints according to their structure and function. State the different types of synovial joints and describe the characteristics features of a typical synovial joint. Outline the different types of fibrous joints and describe their characteristic features. Describe the features of primary and secondary cartilaginous joints. Discuss the secondary cartilaginous joints in detail. Compare and contrast the features of rheumatoid arthritis and osteoarthritis. Classify levels and discuss functional significance of each type. Describe the one packet and loose packet positions, close packet and loose packet positions of major joints of the limbs. Discuss the factors maintaining the stability of the joints. Correctly solve the review questions given at the end of the chapter. Introduction. In general usage, the term joint means a place where two things are joined together. In anatomical usage, a joint is a junction between two or more bones. The long bones articulate by their ends, the flat bones by their margins, and short or irregular bones by their surfaces. It is important for a medical student to know the various synonyms which are commonly used in clinical medicine. The term articulation or orthosis means a joint in Latin. Articulation or orthosis, Latin. The term orthology, for example, study of joints, or the term arthritis, inflammation of the joints, are derived from the term arthron, which means joint in Greek. Basically, a joint is a device to permit movements. However, some joints are immovable. The dislocation is defined as loss of contact, partially or complete, bet- between two articulating bones. Classification of joints. The joints can be classified according to their structure and function. For the sake of convenience of presentation, functional classification is described first. Functional classification. It is based upon the degree of mobility of the joint. They are of three types: immovable joints, synarthrosis; slightly movable joints, ampiarthrosis; freely movable joints, diarthrosis. Immovable joints show no mobility. For example, cranial sutures in adults, primary cartilaginous joints in growing children. Slightly movable joints, ampiarthrosis, show some degree of mobility. For example, secondary cartilage joints, syndesmosis. Freely movable joints, diarthrosis, show maximum degree of mobility. For example, synovial joints. Structural classification. It is based upon the type of connecting tissue and the presence or absence of a joint cavity. The joints are classified into three types: fibrous, cartilaginous, synovial. In clinical practice, the structural classification is most commonly followed, hence will be discussed in detail. Fibrous joints. Here, the bone forming the joints are united by fibrous connective tissue. Therefore, joints are either immovable or permit only a slight degree of movement. A fibrous joint lacks joint cavity. The fibrous joints are of three types: sutures, syndesmos, and gomposis. Sutures. The articular surface are connected by a thin layer of connective tissue. Structural ligaments. These joints are confined to the skull. For example, they are peculiar to the skull and are immovable in growing children. They may permit a little mobility. Depending upon the shape of the articular surface and margin of the articular bones, these joints are further divided into the following subtypes. Plain suture. The articular surface are plain and fairly smooth. For example, medial palatine suture, where the Paired maxillary and palatine bones articulate to form the hard palate, serrate or limbus structure. The articular surface of the bone structures are reciprocal, serrated, and interlocked with each other in a jigsaw fashion. For example, sagittal structure, denticular suture. The margins of the structure interlock with interlock with each other like teeth or saw. For example, limboid structure, squamous structure. The articular surface of the structure are regularly fat and overlap each other. For example, structure between temporal and partial bone. Scandalysis. It is a specialized suture where a ridge of one bone fits into the groove of the other bone. For example, joints between the rostrum of sphenoid bone and the cleft between the alae of vomer bone. Bone plane structure, bone serrate structure, bone denticulate structure, squamous structure, rostrum of spheroid, ala of vomer. Subtypes of studies, clinical correlation, synostosis. In the elderly, most of the structures of the skull undergo ossification leading to rigid bony union, synostosis. For this reason, the skull of children is resilient to blows but not so in adults. In adults, it becomes rigid like an eggshell and frequently splinters following an impact. Thus, fractures of skull are much more common in an adult than in young children. Skull is resilient to blow and but not so in adults. Syndesmosis. There are joints where two adjacent bones are linked together by a considerably greater amount of connective tissue than in structures in the forming interosseous ligament and membranes. For example, interosseous radioulnar joint, interosseous tibiofibular joint, interior tibiofibular joint, joints between adjacent laminae of vertebrae being connected by ligamenta flava, tympanostapedia joints. Slight movement is permitted at these joints. More to know ratio or radius around the ulna in movements of supination and propination. Gumphoses, peg or socket joints. These are specialized fibrous joints restricted to the fixation of teeth in alveolar sockets of the mandible and the maxillae. The root of the tooth is attached to the socket within the alveolus by periodontal ligament. Clinical correlation, periodontitis. The goosebumps, the gumphoses have clinical importance in dentistry because teeth become loose and may fall following inflammation and degeneration of the periodontal ligament. A clinical correlation called periodontitis. Cartilaginous joints. The cartilaginous joints are those joints in which the bone forming the joints are united by means of either hyaline cartilage or fibrocartilage. The cartilaginous joints also lack the joint cavity. The cartilaginous joints are of two types: primary cartilaginous joints, synchondroses, and secondary cartilaginous joints, symphysis. Gomphosis, peg or socket variety, diagrammatic representation, tooth in alveolar socket representing gamphosis. Figure 6.7.6. Primary cartilaginous joints. Synchondrosis. Schematic diagram. Primary cartilaginous joint between epiphysis and diaphysis representing synchondrosis. Primary cartilaginous joints. Synchondrosis. Figure 7.6. 1. Primary cartilaginous joints. The bones or parts of bones forming the joints are jointed by a plate of hyaline cartilage. For example, joints between epiphysis and diaphysis of growing long bone. Joints between diaphysis, phenoid, and basicipus sphenococcal joint. First costosteral joint. These joints are immovable and mostly temporary in nature. As the growth ceases, they undergo stenostosis, i.e., plate of hyaline cartilage is completely replaced by the bone. Clinical correlation. The joints between the epiphysis and diaphysis of a growing long bone are of great clinical significance because piece of hyaline cartilage between the epiphysis and diaphysis allows the growth of long bone in length. Hence, it is also called growth plates, and as growth is completed in height, these joints ossify. Growth plate is clearly seen as a radiolucent shadow between the epiphysis and diaphysis in radiographs. Damage of the epiphyseal plate, particularly at the growing end following structure of a long bone in child, may lead to shortening of the limb. Damage of epiphyseal plate, particularly at the growing end following structure of a long bone in child, may lead to shortening of the limb. 2. Secondary cartilaginous joints. Symphysis.
Tooth in alveolar socket representing bronchophosis. Palate of hyaline cartilage, bone, epiphysis, superficial plate of hyaline cartilage, diaphysis. Primary cartilaginous joint, synchondrosis, schematic diagram. Primary cartilaginous joints between epiphysis and diaphysis representing synchondrosis. Primary cartilaginous joint, synchondrosis. The bones are or part of the bones forming the joint are joined by the palate of hyaline cartilage. Joint between epiphysis and diaphysis of growing long bone. Joint between basis phenoid or by occipital joint. First costosternal joint. These joints are immovable and mostly temporary in nature. As the growth ceases, they undergo synostosis. Plate of hyaline cartilage is completely replaced by bone. Clinical correlation. Joint between the epiphysis and diaphysis of growing bone, long bone are great clinical significance because pieces of hyaline cartilage between the epiphysis and diaphysis allows the growth of long bone in length. Hence, it is also called growth plate. And as growth is completed in height, these joints ossify. Growth plate is clearly seen as a radiolucent shadow between the epiphysis and diaphysis in radiographs. Damage of this epiphyseal plate, particularly at the growing end, following fracture of the long bone in child, may lead to shortening in the limb. Secondary cartilaginous joint, symphysis. In this joint, the articular surface of the bones forming the joint are covered by thin plates of hyaline cartilage, which are connected by discs or a pad of fibrocartilage. Example: the symphysis pubis between two pubic bones, intervertebral discs between bodies of adjacent vertebra, menupro-sternal joint between the menuperum and body of the sternum, symphysis menti between two halves of the fetal mandible. Not true symphysis. Difference between the primary and secondary cartilaginous joints are given in box below. Primary cartilage joints and secondary cartilage joints. Bones are connected by the hyaline cartilage. Bones are covered by the hyaline cartilage and connected by the fibrocartilage. Immobile, slightly mobile. Disappear with age. Don't disappear with age. Rarely occurs in midline. Always occur in midline. And B. Secondary cartilaginous joint typically occur in the midline. All the symphyses belong to the axial skeleton except the pubic symphysis, which belongs to the appendicular skeleton. These joints permit limited movement due to the compressible pad of cartilage. The term of symphysis menti is mentionomer. Secondary cartilaginous joint symphysis, sigmotic diaphragm, pubic symphysis represented the symphysis. Synovial joint. Out of all types of joint, the synovial joints are most common and by far the most important clinically. Therefore, they have been described here in detail. Synovial joint. These joints process a cavity and the articular ends of bones forming the joints are and closed in a fibrous capsule. As a result, they are separated by the narrow cavity, the articular cavity or the joint cavity, which is filled with a fluid called the synovial fluid. Synovial fluid is like an egg albumin. Hence, the name of synovial joint. Synovial joint are the most enveloped and freely mobile joint. They are often termed as dararthodial joints. Dararthodial joints. Characteristic feature of synovial joint are as follows. The articular surface is covered by thin plate of hyaline cartilage. The joint cavity is enveloped by the articular capsule which consists of এখানে চশমা করতে আসলো The joint cavity is enveloped by the articular capsule, which consists of an outer fibrous capsule and inner synovial membrane. The cavity of the joint is lined everywhere by the synovial membrane except over the articular cartilage. The cavity is filled with the synovial fluid secreted by the synovial membrane, which provides lubrication of the articular surface and nutrition of the articular cartilage. Sometimes joint cavity is incompletely or completely divided by the articular disc meniscus. Some additional structure are present within the joint cavity, fat pads and tendons. Diagrammatic representation of a typical synovial joint. Convex articular surface, fibrous capsule, articular cartilage, synovial membrane, joint cavity filled with synovial fluid, concave articular surface. Components of the synovial joint and their functional significance. The following are the components of synovial joint. Fibrous capsule. It completely invests the joint like a slab or and encloses synovial cavity. It is attached by the continuous lines to the bones forming the joint close to the articular cartilage. It consists of the longitudinal and interlacing bundles of white connective tissue fibers. It is lined on the inner aspect by the synovial membrane. The fibrous capsule along with the synovial membrane together forms the articular capsule. Function. The fibrous capsule establishes the joint in such a way that it permits movements by resist dislocation. Numerous sensory nerve endings ramify on the capsule. The simultaneous of these nerve endings produce reflex contraction of muscle acting on the joint in such a way that joint is brought in a position of the maximum comfort of protect the joint. This is known as watchdog action of the capsule. Then fibrous capsule by ligaments. These are thickened bands of the fibrous cartilage, collagen fibers. There are two types, the ligaments and accessory ligaments. The ligaments are the local thickening of the parallel fiber bundles of capsule. Capsular ligaments hence not separate from the capsular ligaments, therefore they are also called the intrinsic ligaments. Medial and lateral collateral ligaments of the joint. Accessory ligaments are separate from fibrous capsule and may be extracapsular or intracapsular. The synovial stylomandibular and the sphenomandibular are the example of the extracapsular accessory ligaments. And anterior posterior cuticate ligaments of the knee joint are the example of the intracapsular accessory ligaments. Playing joint or gliding joint, diagrammatic representation of the joint between the capitate bone and the hamate bone, representing the playing joint. The ligaments permit the movement of in one plane and prevent unwanted movements of other plane. In addition, they are also establish the joint. Accessory ligaments provide the additional reinforcement to the joint and limit the hands of the movements. A tear in the ligaments is called the spring, which leads to swelling and pain in the joint. Synovial membrane. It is thin, highly vascular membrane of connective tissue lining the inside the fibrous capsule. It is reflected from the fibrous capsule on the bone, which is covers right up to the articular cartilage. Note the articular cartilage are not covered by synovial membrane. Function. The synovial membrane produces the synovial fluid in sufficient quantity to keep the surface properly lubricated. The synovial fluid is slippery like an egg white. It is dialysate of blood plasma plus a mucin called the hyaluronic acid. The viscosity and lubricating properties of the synovial fluid are better than those of the commercial lubricants. Articular cartilage. With few exceptions, the articular cartilage is made up of hyaline cartilage. The cartilage consists of proteoglycan hyaluronic acid aggregates. The hyaluronic acid retains water which resists the compression. The cartilaginous articular surface has a low coefficient of friction. Function. The articular cartilage provides smooth friction-free movements and resists compression forces. Articular cartilage of all the synovial joints in the body are thin plates of hyaline cartilage, except those of temporomandibular, sternoclavicular, acroclavicular joint, which are thin plates of fibrocartilage. Therefore, these joints are called the atypical synovial joints. Sometimes a nose cracking sound is produced in the joint. When the articular surfaces are separated forcefully, the sound is produced due to the development of the vacuum within the joint due to forceful separation of the articular surface. Articular discs and meniscus. The articular discs are pairs of fibrocartilage interposed between the articular surface of some joints of temporomandibular, sternoclavicular, acromoclavicular, radioulnar, and knee joints. Function. Helps
Functions helps in lubricant to of joint by maintaining an interval between the articular surface, divides the joints completely into two compartments, acts as ligament to modify certain joint movements, prevents wear and tear of articular cartilage by providing a cushioning effect. Bruise. These are pouch-like sacs of connective tissue filled with synovial fluid. Bursae. Found near certain synovial joints. They are commonly located between tendon and joint bone, between muscle and between skin and bone, and between tendon and skin. Brucei. These are pouch-like sacs of connective tissue filled with synovial fluid found near certain synovial joints. They are commonly located between tendon and bone, between muscle and bone, between skin and bone, and between tendon and skin. The brucei reduces the friction of one structure moving over the other. Function. The function of brucei is to cushion certain muscles and to facilitate the movement of tendon or muscle over bony or ligamentous surfaces. The synovial tendon sheath is a modified bruise that surrounds the lubricants, the tendons of certain muscles, particularly those that cross the wrist and ankle joints. Fat pads. Harvesian glands. These are pads of fat placed between synovial membrane and fibrous capsule or between synovial membrane and bone. For example, acetabular fat or hip joint. Infrapatellar fat, pad to knee joint. As fat is very pliant, the pads can accommodate themselves to changing conditions of the joint during different movements. Clinical correlation. These tissue involved in diseases of the synovial joints are hyaline cartilage, bone and synovial membrane, osteoarthritis. Under normal condition, the articular surface of bones of synovial joints do not come in contact with each other. Because articular surface of bones are capped by articular cartilages and synovial fluids within the joints provides lubricant to these cartilages. If articular cartilages are damaged due to the trauma or disease, or if the synovial fluid is reduced, the articular bones come in contact with each other and undergo artition. The bones begin to degenerate. There are abdominal bone repair and articular surface bones uneven, misshapen, causing osteoarthritis. It affects large weight bearing joints. For example, hip and knee joints are most most involved in osteoarthritis. These are the sometimes there is formation of osteophytes. Formation of osteophytes. The zone of articular bone at the junction of articular cartilage, synovial membrane, and periosteum is highly vascular. It is endowed with immense proliferative power and hence the site for formation of osteophytes, pseudobone formation, which leads to lipping or articular margins. Rheumatoid arthritis. It is a chronic progressive inflammation autoimmune disease involving synovial membrane. This leads to hypertrophy and hyperplasia of synovial cells and fibrous inflammatory effusion into the joints. If disease progresses, it will cause erosion of articular cartilage and growth of granulation tissue that separates the bones and distorts that shape the joint. Rheumatoid arthritis commonly affects the small joints and hands and feet. Table 7.1 highlights difference between arthritis and rheumatoid arthritis. Arthroplasty. It is a surgical repair or replacement of joints. Recent advancements in soft tissue repair involves the use of articular ligaments made out of carbon fibers coated with plastic polylactic acid. Classification of synovial joints according to the shape of articular surface. Plain joints. The articular surface are nearly flat. They permit grinding movements in various directions, for example, side to side, back and forth movements with slight rotation. These are the simplest types of joint movements. The examples are intercarpal joints, intertarsal joints, intermetatarsal joints, intermetacarpal joints between the articular process of adjacent vertebrae, zygapophyseal joints, hinge or gingivalous joints. The articular surface are pulley shaped. Movements are permitted. Features of osteoarthritis and rheumatoid arthritis. Nature of disease: osteoarthritis and rheumatoid arthritis. Nature of disease: degenerative and inflammatory. Inflammatory and autoimmune. Tissue effect: articular cartilage, synovial membrane. Joint affected: weight bearing, for example, hip joints, joints of cervical and lumbar spine, small joints of hands and feet. Saddle or cellar joints. The articular surface are reciprocal saddle shaped, for example, concavo-convex. This unique articulation is modified condyloid joint that that allows a wide range of movement. The examples are first carpo metacarpal joint, sternoclavicular joint, calcaneoclavicular joint, inguinalomalleolar joint, smallest saddle joint, ball and socket or spheroidal joints. Ball and socket or spherical joints, rounded convex surface of bone fits into the cup and socket of another bone. The movements occur around an indefinite number of axes which have one common center. The type of articulation provides the greater range of movements of all the synovial joints. The movements include flexion, extension, adduction, abduction, medial rotation, lateral rotation, and circumduction. The examples are hip joint, largest ball and socket joint, shoulder joint, incudostapedial joint, smallest ball and socket joint. The examples of various types of synovial joints according to the shape of the articular surface are summarized in table 7.2. Figure 7.1 for saddle joint A. Diagrammatic representation. First, carpo-metacarpal joint representing saddle joint. Figure 7.1 for ball and socket joint. Diagrammatic representation of the joint showing direction of the possible movements. Hip joint representing ball and socket joint. B. According to the planes of movements. Uniaxial joint. In these joints, the movements occur in only one plane or axis. The examples are hinge joints, for example, elbow, ankle, and interphalangeal joints. Here, movements take place around a transverse axis. Hence, only flexion and extension is possible. Pivot joints, for example, superior radio ulna and medial atlantoaxial joints. Here movements take place around the vertical axis, hence only rotation is possible. Biaxial joints. In these joints, the movements occur in two planes or axes. The examples are condylar joints, for example, knee and temporomandibular joints. There are modified hinge joints where not only flexion and extension takes place around the transverse axis but slight rotation also takes place around the vertical axis. Ellipsoid joint, for example, radiocarpal, metacarpal, phalangeal, metatarosophalangeal, and lateroatlanto-occipital joints. Here, flexion and extension takes place around transverse axis, and abduction and adduction takes place around the anterior posterior axis. Figure 7.17. The circumduction of is also possible. Saddle joints, for example, carpo-metacarpal joints of the thumb, sternoclavicle joint. Here, flexion and extension takes place around the transverse axis, and abduction and adduction takes place around an anteroposterior axis. Some rotation is also associated with aphoreset movements. This is known as conjunction rotation. Multiaxial joints. In these joints, movements occur in three planes or axes. Figure 7.18. The examples are ball and socket joints such as shoulder and hip joints. All kinds of movement, for example, flexation, extension, abduction, adduction, rotation, circumduction are possible. According to the number of articulating bones, simple joints. Here only two bones take part in formation of a joint. For example, interphalangeal joints of fingers and toes. Compound joints. Here more than two bones take part in the formation of a joint. For example, are ankle joint where three bones, tibia, fibula, talus, take place to form the joints. Elbow joint. Here three bones, humerus, radius, and ulna take part to form this joint. Radiocarpal wrist joint where four bones, radius, scaphoid, lunate, and triquetral, take part in the formation of the joint. Note well, when the joint cavity is divided into two compartments by a articular disc or meniscus, it is called complex joint. For example, knee. Figure 7.1 7.19 Temporomandibular and sternoclavicle joints. Examples of various types of synovial joints according to their articular surface: intercarpal, intertarsal, intermetatarsal, intermetacarpal, zygapophyseal. Hinge: elbow, knee, ankle, interphalangeal. Pivot: superior radio ulnar, medial atlantoaxial, temporomandibular, metacarpophalangeal, radiocarpal, atlanto-occipital, metacarpophalangeal, metatarsophalangeal. Saddle: first carpometacarpal, sternoclavicular, calcanea cuboid, inguinalomolar, hip joint, shoulder joint, inguinostephatal, smallest. Figure 7.16 Superior radioulnar joint. 1. Diagrammatic representation of the joint showing vertical axis V. Actual superior radioulnar joint. Figure 7.72 Axis of a multiaxial joint AP. Antero-posterior axis producing abduction and adduction T. Transverse axis producing flexion and extension. Figure 7.18 Axis and movements of a polyaxial joint AP. Anterior posterior axis to transverse axis V. Vertical axis. Popliteus, lateral congenital ligament, lateral meniscus, cruciate ligament, medial meniscus, medial collateral ligament. 7.90 Knee joint, an example of complex joint. For femoral, condyle, TC, tibial, condyle. Movements of synovial joints. Active movements. 3 types of active movements occur at the synovial joints: gliding or slipping movements, angular movements, rotary and circulatory movements. Gliding or slippery movements. These movements occur in plane joints, where one bone slips over the other in a particular direction. Such directions are limited. The series of gliding movements in small joints of hand, foot, and vertebral column provides an efficient buffer against a force. Regular movements. These movements increase or decrease the types of angular produced by the articular bones. The 4 types of angular movements are as follows. Movements of synovial joints. Active movements. 3 types of active movements occur at the synovial joints: gliding or slipping movement, angular movement, rotatory or circular movements. Gliding or slipping movements. These movements occur in plane joints, where no bone slips over the other in a particular direction. Such movements are limited. The series of gliding movements in small joints of hand, foot, and vertebral column provide an effective buffer against a force. Angular movements. These movements increase or decrease the joint's angular produced by articular bones. The 4 types of articular bones are as follows. Flexation. It is the movement that decreases the joint angle in an anterior plane. For example, bending of elbow and knee. The flexion of elbow joints is forward movement, whereas flexion of knee backwards is a backward movement. Note well, in ankle joint, the flexion occurs when the dorsal of the foot is elevated. This movement is termed as dorsiflexion. The raising of toe is plantar flexion. In flexion of shoulder joint, the arm is brought forward, extension. This movement is reverse of flexion, and it is the joint angle is increased. In an extended joint, the angle between the articular bones is 180 degrees. The extension returns the body part to the anatomical position. The exception to this is the ankle joint, where there is a 90-degree angle between the dorsal of the foot and the lower leg in an anatomical position, so that the joint angle is greater 100 degree. For example, turning the backward whereas rotation of knee during locking and unlocking is a conjunct rotation. Circumduction, it is a special active movements. These are as follows: inversion, movements in which the sole of the foot faces inward and medially. It occurs when the medial border of the foot is raised. Eversion, movement in which the sole of the foot faces outwards and laterally. It occurs when the lateral border of the foot is raised. Note well, the movement of inversion and eversion occurs at subtalar, talocalcaneonavicular and midstal joints. The range of motion of inversion is more than that of eversion. These movements correspond to movements of supination and pronation in the upper limb. Pronation, forward movements of the body part on a plane parallel to the ground. For example, protraction of the lower jaw. Retraction, pulling back the protraction part of the body on the plane parallel to the ground. For example, protraction of the lower jaw. Eversion, the part of the body is lifted upwards. For example, elevation of the mandibular to close to the mouth. Lifting of the scapular to shrunk the shoulder. Depression, the part of the body is moved downward. For example, depression of mandibular to open the mouth. The active movements possible at synovial joints are summarized in table 7.3. Passive and accessory movements. The passive movements are produced by an external force such as gravity or examining doctor. For example, the doctor holds the patient's wrist so as to immobilize. He can then flex, extend, abduct the hand at rest. The movements the patient can normally carry out actively by himself by carrying manipulation. The examining doctor can also produce a slight degree of grinding and rotation at the wrist, where these movements the patient cannot carry out actively by himself. Hence, they are called accessory movements. Clinical correlation. These assessments of passive and accessory movements is of great value in testing and diagnosing muscle and joints disorders in clinical practice. Blood supply to synovial joints. It is derived from particular network of arteries, circles, arteries, vasculars that surround the joint. This network is formed from the branches of the arteries lying in the vicinity of the joint. It supplies the capsule, synovial membrane, and epiphysis. Note where articular cartilage are avascular, fibrous capsule and ligament have poor blood supply. Synovial membrane is richly supplied by blood. The rich vascular plexus of synovial membrane also helps to supply nutrition to the periphery of the articular cartilages. Table 7.3. Movements possible at synovial joints. Movement: angular movements, flexion, extension, abduction, adduction, circumduction. Special movements: rotation, supination, pronation, inversion, eversion, protraction, retraction, eversion, and depression. Note well, the fusion between epiphysis and diaphysis occurs 2 or 3 years earlier in females. The fusion between epiphysis and diaphysis occurs 2 or 3 years earlier in females. Hence, they are shorter in length than males. Metaphysis: the end of diaphysis toward the epiphysis cartilage is called metaphysis. It is the most actively grown area in a long bone. Before fusion of epiphysis, the metaphysis profusely supplied by blood from nutrient, periosteal and juxtaepiphyseal arteries. These are end arteries and form hairpin-like bends. Therefore, metaphysis is the common site of osteomyelitis in children for bacteria and emboli are easily trapped in the hairpin bends, leading to infraction. After the epiphyseal fusion, the communications are established between the epiphyseal and metaphyseal arteries. As a result, metaphysis contains no more end arteries. For this, for this reason, osteomyelitis in this region is rare in adults. Diaphysis. It is the elongated part of bone between the metaphyses. It develops from primary ossification center. Blood supply of bones. Blood supply of a long bone. The long bone is supplied by the following four sets of arteries: nutrient artery, periosteal artery, metaphyseal arteries, and epiphyseal arteries. Nutrient artery. It enters the middle of the shaft through a nutrient foramen, runs obliquely through the cortex, and nutrient artery. It enters the middle of the shaft through a nutrient foramen, runs obliquely through the cortex, and then divides into ascending and descending branches in the medullary cavity. Each branch then subdivides into a number of smaller parallel vessels which enter the metaphysis and form hairpin loops. The loops anastomose with epiphyseal, metaphyseal, juxtapiphyseal, and periosteal arteries. Therefore, the metaphysis is the most vascular zone of the long bone. The nutrient artery supplies the medullary cavity containing bone marrow and inner two-thirds of the outer shell of the compact bone of diaphysis and metaphysis. Note 12. Oblique direction of nutrient foramen in shaft is opposite to the growing end of the long bone. Before entering the nutrient foramen, the nutrient artery is tortuous, so that it is not affected during the movement of the bone. The nutrient artery of tibia is the largest nutrient artery of the body. Periosteal arteries. They are numerous and ramify beneath the periosteum. They enter the bone through Volkmann's canals to supply the outer one-third of the cortex. The periosteal vessels are especially numerous beneath the muscular and ligamentous attachments. Metaphyseal, juxtaepiphyseal arteries. They are derived from neighboring arteries and enter the metaphysis directly along the attachment of the joint capsule. Epiphyseal arteries. They are derived from arteries anastomosis around the joints, circular vasculosus. They enter the epiphysis either directly or after piercing the epiphyseal cartilage. Blood supply to long bones. To an extent, it is similar to the of a long bone, except that the nutrient artery enters the middle of the shaft and immediately divides to form a plexus. The periosteal vessels supply the major part of the bone in adult and replace the nutrient vessels. Clinical correlation: osteomyelitis. In typical long bones, infection occurs in the metaphyseal regions. Firstly, because they are rich supply with blood, and secondly, because the blood supply in the metaphysis is through end arteries, forming hairpin bends. Therefore, the bacteria and emboli are easily trapped in these hairpin bends, leading to infraction, necrosis in bone, resulting in a clinical condition called osteomyelitis. In short, long bones. The infection begins in the middle of the shaft because nutrient arteries enter the middle of the shaft and immediately divides to form the plexus. The blood supply of bone is so rich that the passing of a metal pin cannot interrupt the passing of a metal pin cannot interrupt blood supply sufficiently to kill the bone. The supply is so rich that blood supply of a vertebra. It is supplied by three sets of vessels. One or more large but short vessels enter the body from the posterior aspectro-vertebral foramen. A set of small vessels pierce, pierce the anterolateral surface of the body. A set of long vessels pierce the root of the transverse process and supply the vertebra arch and transverse and spinous process. Blood supply of a rib. It is supplied by two sets of vessels. The nutrient artery which enters it just behind the tubercle, the periosteal arteries. Note well. The veins are numerous in cancellous bone. For example, in the vertebrae, they join to form large basivertebral vein. In the compact bone, they accompany the arteries to the Walkman's canals. There are no lymphatic in the bone. However, some lymph vessels do accompany the periosteal blood vessels and drain in the regional lymph nodes. Fracture of the bone. The fracture is a break in the continuity of the bone. It is the most common type of bone injury. Fracture mostly occurs due to traumatic fractures. However, they may occur spontaneously due to disease that weakens the bone spontaneously or pathological fractures. A fracture may be simple or compound, simple or closed fracture. The fracture bone is not exposed to the exterior through skin. Compound fracture. The fracture bone is exposed to the exterior through an opening on the skin. When a bone fractures, the treatment involves real, realizing the broken ends, realigning the broken ends, and then immobilizing them until the fracture is healed, repaired.
Fracture bone. It involves the following steps. When bone is fractured, the blood collects and coagulates to form the fracture hematoma in and around the fracture site. 2 or 3 days later, new bone capillaries and uncommitted cell forms the surrounding tissue invade the hematoma. After 1 week, some of the uncommunicated cell different into the fibroblast, which produce a fibrous network between the fractured ends. The other cells differentiate into chondroblast, which produce islets, islets of fibrocartilage in fibrous network, forming a fibrocartilage callus, temporary callus. The osteoporogenerator cells in the periosteum and osteum around the fracture site proliferate and differentiate into the bone-forming cell, the osteoblast, which invade the temporary callus and lay down to the oven bone, primary bone tissue or osteoid, which unites the extremities of the fractured bone. It is called the bony callus. The primary bone tissue of the callus and gradually replaced by a secondary bone, mature bone. Remodeling takes place and restore the original bone. Development and growth of bones. All the bones develop from a mesenchyme by process called the ossification. Ossification, as stated above, it is process of the bone formation. Types of ossification. There are two types of ossification: intramembranous ossification, intercartilaginous ossification. In intramembranous ossification, mesenchymal models of bones undergo ossification, while intercartilaginous ossification, cartilaginous models of bones undergo the ossification. Details as under. The intermembranous ossification, it involves the following steps. The mesenchymal tissue condenses to form a membranous sheath model. Osteoprogenitor cells located in the sheath differentiate into the osteoblast. The site where the osteoblasts first appear are called the ossification center. Osteoblast secretes organic substance, ground substance, and collagen fibers in the intercellular space to form the osteoid tissue or bone matrix. Under the influence of alkaline phosphatase secreted by osteoblasts, the osteoid tissue is mineralized with calcium salts to become bone. The osteoblasts now become trapped in mineral matrix and are called the osteocyte. The intramembranous ossification is shown in bone formed by the intermembranous ossification include the flat bone of the skull, example the frontal, parietal, occipital, clavicle. Clinical correlation: cranial dysostosis. It is the congenital condition presenting the following features: complete or parietal absence of clavicle. It is a cleidocranial dystosis. Defective development of the cranial vault with large fontanelle and the delayed closing of the sutures. This condition occurs due to the defective intermembranous ossification. Intracalygenous endochondral ossification. The intracalygenous ossification is more complicated but clinically more important because all the long bones of limbs and many others are ossified by the process. Steps of the intermembranous ossification. Mesenchymal model, formation of the osteoblast, formation of the osteoid tissue, and mineralization of the osteoid tissue. It involves the following steps. Step 1. The cartilaginous cells, chondroblast of the cartilaginous model enlarged and matrix surrounding them is called calcified under the influence of alkaline phosphatase secreted by the cartilaginous cell. The cartilage cells are and disappeared, leaving between empty space called the primary areolae. The cells on the surface of periosteum differentiate into the osteoblast, which enter at the site of ossification along with blood vessels. Periosteal bud. Step 4. The most of calcified matrix is absorbed, forming large empty spaces called the secondary areole, leaving behind only thin bars of the calcified matrix. The new bone osteoid is laid down on the surface of calcified bars of the matrix. The mineralized of the osteoid. Step 6. Ossifies of a long bone. Following of the simplified account of intracartilaginous ossification of long bone. First, the long bone is laid down as a hyaline cartilaginous model surrounded by the pericardium. Step 2. A primary center of ossification then appear in the center of the shaft, and this is spread toward the ends of the form of diaphysis. At the same time, periosteum lay down a collar of bone, periosteal collar, around the circumference of the shaft. Step 4. Later, one or more secondary centers of ossification developed at each end of the cartilaginous model and from the epiphysis. The epiphyseal cartilage separating epiphyseal from epiphysis and articular cartilage, each end of the bone remain cartilaginous. Step 6. The epiphyseal plate of the cartilaginous continues to produce new cartilages and thus enables the bone to grow the length. For these reasons, epiphyseal plate of cartilage is also called the growth plate. Once the growth in length is completed, the remaining epiphyseal cartilage ceases to proliferate and becomes ossified, leveling only as epiphyseal scar called epiphyseal line. Ossification center. These are sites where bone formation begins. The ossification center are generally classified into two types: primary and secondary. Primary ossification center appear before birth, usually between the 7 to 12 weeks, with some exception like the primary center of the tarsal and carpal bones appear after birth, except those of talus, calcaneus and cuboid. Secondary center of ossification appear as a rule after birth, usually from the time of birth of 5 years of age. A primary center forms the centers diaphysis and the secondary center from the epiphysis. The fusion of epiphysis with the Diaphysis starts at puberty and is usually complete by the age of 25 years. Therefore, after the age of 25 years, no more bone growth can take place. In general, the appearance of secondary centers and fusion of epiphyseal occur about 1 year earlier in females than in males. All the secondary centers appear after birth except the one at the lower end of the femur, which appears the ninth month of the uterine life and sometimes at the upper end of the tibia and humerus. Clinical correlation. The visibility of center of classification in the distal end of the femur in radiograph of newborn child found dead is of the medico-legal importance because it indicates that the child was full term. In X-ray of newborn, the shaft of the long bones present a while the radio-opaque shadow, whereas end of the joint and black radiolucent shadow. This is because at the birth the shaft of the cartilaginous model is ossified. Example, bony but ends of the still ossified cartilaginous. On the other hand, in X-ray growing child, the shaft and epiphyseal cast while the radio-opaque shadow, but the epiphyseal plate between the epiphysis and diaphysis cast a back radiolucent shadow. Achondrophysis. It is a congenital condition with the following clinical feature. Individual is abnormally short, dwarfed, disproportionately shorter limb than trunk, dorsal kyphosis and lumbar lordosis. The condition occurs due to the defective endochondral ossification. Radiograph of a full-term child showing the secondary center of the ossification at the distal end of the long bone. Arrow distal end of the long bone secondary center. Source figure at the clinical embryologically. Now it's a textbook of clinical embryology থেকে the বিশ্রাম সিং copywriter আচ্ছা তারপর growing end of the long bone. In most of the long bones, the two epiphyses don't fuse simultaneously. The epiphyses at the one end always fuse few years before that of a other hand. The end at which the fusion occurs later is called the growing end, and this is also the end at which the secondary center of ossification appear first. Growing end is always located opposite to the direction of the nutrient foramen. The direction of the nutrient foramen is easily remembered by the dictum that says the to elbow I go, from knee I feel. To elbow I go, to knee I feel. The milking cow position showing the direction of the nutrient foramina. In the milking cow position, the direction of the nutrient foramina is always downward. Thus, the upper limb, shoulder, end of the humor, wrist end of the ulna, radius are growing ends, whereas the lower limb, knee, and also the femur, tibia, fibula are the growing end. Growing end কোনটা বুঝতে হবে নি লোয়ার লিম্ব হলো নিচের গুলা আপার লিম্ব হচ্ছে উপরের গুলা বুঝছো upper limb, shoulder end of the humerus, wrist end of the ulnar, radius are the growing end, whereas the lower limb, the knee ends of the femur, tibia, fibula are the growing end. The nutrient foramen in the shaft of the long bone is always directed opposite to the growing end, except that in the shaft of fibula which direct forward the growing end. Law of union of epiphysis. According to the law, the epiphyseal center, secondary center of the ossification, which appears first, unites last, and epiphyseal center, which appears later, unites first, except in case of fibula, where the epiphyseal center for lower end appears first, also unites first. ফার্স্টে হয়েছে লাস্টে ফার্স্টে তাও ইউনাইট হয়ে গেছে. On the other hand, epiphyseal center of the upper end appears the late and the unites. Thus, fibula is the only long bone which violates the law of union of epiphysis. Growth of long bone. The growth of long bone after birth ossified by two two methods, the positional growth or endochondral growth. The bones cannot grow by an interstitial growth like the tendons, ligaments, and cartilage. The epistemial growth. The epistemial growth refers to the addition growth at the periphery of the bones, resulting in an increase in the diameter of the long bones. The epiphyseal growth. The osteoblast on the surface of the bone proliferate. The surface osteoblasts produced from thus division remain as much as such as divided again. The deep osteoblast resulting from these divisional produce bone matrix, and when they are surrounded by matrix they become osteocytes. Consequently, a new layer of bone is deposited on the surface of the bone. In calcareous bone, appositional growth ends bone matrix to the outer surface of the trabeculae. Endochondral growth. The endochondral growth is responsible for an increase in the length of long bones. The endochondral growth occurs due to the multiplication of the cells of the epiphyseal plate of cartilage. Surface of epiphyseal plate facing toward epiphysis gives rise to new cartilage which pushes the epiphysis away from diaphysis. The amount of new cartilage produced is equal to the amount of cartilage replaced by the spongy bone toward the metaphyseal surface of the epiphyseal plate, leading to the increase the length of diaphysis. The thickness of epiphyseal plate remains almost the same. Details as under. The epiphyseal plate is organized into two zones from superficial to deep. These are the zone of resting cartilage, zone of proliferation, zone of hypertrophy, zone of calcification. The zone of resting cartilage is nearest to the epiphyseal and contains randomly arranged chondrocytes which don't divide rapidly. In the zone of proliferation, the chondrocytes proliferate and form the longitudinal columns of young cartilage cells and resemble stacks of plates or coins. In the zone of hypertrophy, the chondrocyte mature and hypertrophy. These secrete alkaline phosphatase. Thus, maturation gradient exists in each column of chondrocyte. The cells near the zone of resting cartilage are younger and actively proliferating, whereas the cells progressively near to the diaphysis are older and they undergoing hypertrophy. Zone of calcification is very thin. It consists of matrix mineralized the calcium carbonate. When the hypertrophied chondrocyte die, the blood vessel from diaphysis grow into this area. The connective tissue surrounding the blood vessel contains the osteoblasts from the endosperm. The osteoblasts line up on the upper surface of the cartilage, calcified cartilage, and deposit bone. Clinical correlation. Growth in height. The epiphysis plates of long bone of the upper and lower limbs are resembles for growth in height of the individual. On the epiphysis unite with diaphysis, the growth is height stop. The sex hormones stimulate the ossification epiphyseal plate, leading to union of epiphysis with diaphysis. In females, the estrogen causes the early closure of epiphysis with diaphysis as compared to that of testosterone. Consequently, females usually don't reach the same height as males. The damage to the epiphyseal plate growing under the long bones or leaves of growing children will lead to shortening of the limb because damage of the epiphyseal plate interferes of the elongation of the long bone. Remodeling of bone. The bone does not grow by multiplication of the cells by increase the intercellular material or interstitial growth. Hence, the shape cannot maintained. The bony growth by the deposition of new bone by osteoblast on the ends and its surface is random fusion. Therefore, to maintain its shape, the unwanted bone is removed by a osteoclast. This process of bone removal is called the remodeling, surface remodeling. As the bone grows in length, this occurs superficial bone deposition in the shaft where the
Surface remodeling. As the bone grows in length, there occurs subperiosteal bone deposits in the shaft, while subperiosteal bone resorb- reabsorption occurs in the clinical region towards the end. Functions of the skin. The skin is a dynamic organ. It not only protects the body from pathogens and external injury but also plays a major role in maintaining body homeostasis. The major functions of the skin include protection, hydroregulation, i.e., prevents the loss of body fluids, thermoregulation, sensory res- reception, i.e., for example, acts as a sensory organ, absorption of lipid soluble substances and ultraviolet rays, synthesis of vitamin D, excretion of waste material, communication of emotions, protection. Skin acts as a protective barrier between the external environment and internal tissue of the body. It protects the body from pathogens and external injury. Hydroregulation. Skin being virtually waterproof, it prevents dehydration, loss of body fluids in hot weather, and absorption of water when immersed in water. The waterproofing is provided by cornified layer of the skin. Thermoregulation. Skin plays a crucial role in regulation of body temperature. It maintains the normal body temperature, for example at 37 degrees Celsius, by effects of sweating and shivering. The excess heat is lost from the body by three ways, all involving the skin: through the secretion and evaporation of sweat, through radiation from dilated blood vessel, and through convection of heat directly through skin. The heat is conserved by the fat and the hair. Sensory reception. Skin is an important sensory organ for perceiving sensations like pain, touch, temperature, and pressure. This is because skin contains a large amount of sensory nerves ending called cutaneous receptors. Absorption. Skin being a protective barrier, it has limited capacity of absorption. Lipid soluble substances such as vitamins A, D, E, and K are absorbed slowly. Some gases, for example, oxygen and carbon dioxide, may pass through the skin into blood. Small amounts of ultraviolet lights are absorbed readily and contain toxins and pesticides entering the body through the skin. Synthesis. Vitamin D is synthesized in skin with the help of ultraviolet rays of the sun. In addition, creatine and melatonin are also synthesized in the skin. The melanin and keratin remain in the skin while vitamin D is used elsewhere in the body. Excretion. The skin also acts as an excretory organ. The excess of water, salts, and waste products such as ammonia and urea are excreted through the skin by sweating. Communication of emotions. Skin can also communicate emotions. For example, in anger, a person's face becomes red, and in anxiety, the becomes cold and the damp, or the person may start swelling.
The epidermis of the skin is avascular. Blood vessels within the dermis supply the glands and hair follicle within the dermis, and metabolically active serum bacilli of the epidermis. A special feature of the blood supply to the skin is the presence of numerous arteriovenous anastomosis which regulate blood flow through the capillary bed and thus help in maintaining the body temperature. Clinical correction. Correlation. Bad source. Proper circulation of blood is in skin is essential for the healthy skin. When a person lies in one position on bed for a long period, the dermal flow of blood is reduced at sites where the blood pressure against the bed. As a result, cell necrosis occurs in all these sites, leading to ulceration. The ulcer thus produced are called the bed sores and decubitus ulcer. Nerve supply of skin. Nerve supplying to the skin are motor nerve, sensory nerve. Motor nerves. There are autonomic nerve fibers which activated glands and control blood flow. Sensory nerves. These are somatic nerve fibers which innervate the skin in the form of large number of sensory nerve endings which carry different types of sensation from the skin. Sensory nerve endings in the skin. Free nerve endings enter the epidermis and carry pain and temperature sensation. Michel's discs or ending terminate on the Merkel cells of the stratum basally and function as the mechanoreceptors. The Messiner's corpuscles are present in the dermal papillae and function as the mechanoreceptors to direct fine touch. Pacinian corpuscles are present in the dermis and function as the mechanoreceptors to detect deep pressure and vibrations. Raffinus endings are present deep within the dermis and function to the heat receptor of the detect heat. Bulbs of Kersey are located in the superficial part of dermis and function of the thermoreceptor to decay cold. Sensory nerve ends in the skin. Text book of clinical neuroanatomy, Bistram Singh and copyright of exclusive tag. The root hair plexus are the plexus of nerve fibers around roots of hair follicles and function a tactile receptors to detect movement. All the cutaneous receptors are located in the dermis except free nerve endings and Meckel's discs which are located in the epidermis. Wound healing. The healing of wound occur in 3 steps of stage: inflammation, proliferation, maturation. Inflammation. The cut surface become inflamed. Blood clots and cell debris fills the gap between them the first few hours. The phagocytes and fibroblasts migrate into the blood clot. Phagocytes remove the blood clot and cell debris. Fibroblasts secrete collagen fibers which bind the cut surface. Proliferation. The epithelial cell proliferate across the clot. The epidermis meets the grows upwards until the full thickness is restored. Granulation tissue consisting of new capillary buds, phagocytosis and fibroblasts develop. The fibroblasts continue to secrete collagen fiber as the clot and any bacteria are removed by phagocytosis. The clot above the new tissues becomes the scalp and separates after 3 to 10 days. Maturation. Granulation tissue is placed by fibrous scar tissue. Healing is described to be 2 types: primary healing, healing by the first intention, and secondary healing, healing by the second intention. Primary healing flows minimal destruction of tissue when the damage age of the wound are in close opposition. The secondary healing allows destruction of a large amount of tissue or when age of wound cannot be brought in opposition. The stage of healing are same in both types. Skin burns. The skin burns are generally caused by heat, electricity or chemicals. The skin burns are classified as first degree, second degree, third degree based on their severity. First degree burn destroy only epidermis. Presenting symptoms are redness, pain, edema or swelling. Shedding of the surface layer a few days later, heals in a 3 to 6 days. Second degree burn involve epidermis and part of dermis. Blister appear, heals completely within few weeks. Third degree burn destroy both epidermis and dermis completely, frequently some of the underlying muscle. Skin appears waxy or changed. Are invasive to touch. Wounds develop, heals by forming scar tissue. Requires skin grafting to promote healing. Major burns include third degree burn involving 10% of body surface, or second degree burns involving over 20% or 25% of body surface. Estimation of surface area of skin. The total surface area of skin covering the entire body is 1.5 to 2 square meter. The estimation of the percentage of surface area damage in case of burn is important in treating the patients with intravenous fluid, which replace the fluids lost from tissue damage. Rule of time. This rule is quick means of estimating the surface area affected by burn. According to this rule, the total surface area of the body is divided into regions, each of which accounts for 9% or multiple of 9% of total skin surface. Head area rule. Hand area rule. A rough estimation of surface area affected by burn can be calculated by hand area rule. According to this rule, the area of the patient hand is approximately 1% of the total body surface. Regeneration of skin. The skin has hand area rule. Rule of 9 and hand area rule. Rule of 9 the rule is quick means of estimating the surface area affected by burn. According to rules, the total surface area of the body is divided into region, each which accounts for 9% of the multiple 9% of the total skin surface. 9% বলে আমরা রুল অফ 9, বার্নটা 9% বোঝায় যে রুল অফ 9 এটা। আর হ্যান্ড এরিয়া রুল, a rough estimation of surface area affected by burn can be calculated by hand area rule. According to this rule, the area of patient hand is approximately 1% of total body percent. 1% যখন হয় তখন হ্যান্ড এরিয়া রুল, 9% বার্ন হলে সেটাকে রুল অফ 9 বলে। Regeneration of skin. The skin has highly capacity of regeneration and repair. For this reason, the skin grafting is common procedure in plastic surgery, especially after burns.
Estimation of surface area of the skin. The total surface area of the skin covering the entire body is 1.5 to 2 square meters. The estimation of the percentage of surface area damaged in case of burns is important in treating the patient with intravenous fluid, which replaces the fluid loss from the tissue damage. Rule of 9. The rule is a quick means of estimating the surface area affected by burn. According to this rule, the total surface area of the body is divided into regions, each of which accounts for 9% or multiple of 9 of the total skin surface. Table 5.3, figure 5.9. Hand rule area. The rough estimate of the surface area affected by burn can be calculated by hand area rule. According to this rule, the area of patient's hand is approximately 1% of the body surface. Regeneration of the skin. The skin has high capacity of regeneration and repair. For this reason, the skin grafting is a common procedure in plastic surgery, especially after burns. If a patch of epidermis gets removed, the repair and regeneration takes place by a proliferative activity of the stratum germinativum. However, there is no regeneration of hair follicles. If the dermis repairs intact, the pattern of papillary ridges, fingerprints, is reproduced as earlier. If the dermis is damaged, the papillary ridges regenerate but do not conform to the original pattern. Superficial fascia. It is a subcutaneous layer of loose areolar tissue which unites dermis of the skin to the underlying deep fascia. It allows mobility of the dermis on the underlying structures. The surface area of the skin in percentage for various regions of the body: head and neck 9%, right upper limb 9%, left upper limb 9%, Anterior surface of the trunk 18%, posterior surface of the trunk including buttocks 18%, left lower limb 18%, peritoneum 1%, perineum 1%, total 1%. It is heavily infiltrated with fat. The amount of fat varies in different parts of the body. The superficial fascia, almost everywhere in the body, contains fat except in the eyelids, external ear or pinna, and penis. Extensor for femoral nerve.
Extended femoral nerve.
Figure 5.10, transverse section through the middle of the right thigh to show the three intermuscular septa and three osteophysi compartments as seen from above. Fat except eyelids, external ear, penis, scrotum, flexion, creation of the digits, flexing creases of the digits. The, the amount of fat in superficial fossa is more in females and in children. The fat being a bad conductor of heat, the females and children feel less cold. Further, it is the main factor responsible for the smooth external contours of the females, especially fat deposits at certain sites in women from their secondary sexual characteristics. These sites are gluteal and lumbar region, front of thigh, anterior abdominal wall below the navel, umbilicus, breasts, post deltoid region, clavicle thoracic region.
Fascia act as a distributing layer in which the blood vessel lymphatic nerves can travel before entering the dermis. The subcutaneous fascia in the lower animal contain a sheath of muscle called the panniculus carnosus. Its fibers are inserted into the skin. The twist of its fibers prompts the insect to go away or fly off. In humans, the panniculus cornices is represented by muscle of fascia expression, skeletal muscle, platysma in the neck, skeletal muscle, subareolar muscle of the waist, smooth muscle, palmaris brevis, skeletal muscle, dartos in the scrotal wall, smooth muscle, corrugator cutis ani, smooth muscle. Function of the superficial fascia. Function of the superficial fascia of the skin forms layer, forms an insulating layer deep to skin, responsible for smooth external contours of females and children, allows mobility of the skin on the underlying structure, provides easy passage to nerve vessel and lymphatics, acts a cushion of certain sites due to excessive accumulation of fat like buttock. Clinical correlation. Subcutaneous injection. A. Subcutaneous injection are painful due to the presence of pain receptor in it. Drugs administered by this route are absorbed slowly because subcutaneous tissue are poor blood supply. Only a small dose, 0.5 to 1 millimeter of water-soluble drugs are given subcutaneously. For example, insulin injection in diabetic person, are given subcutaneously. Small doses for slow release in diabetic person are given subcutaneously in small doses for slow release over a long duration. Site of subcutaneous injection. Ideal site of subcutaneous injection: posterior aspect of arm, anterior aspect of forearm, anterior abdominal wall, anterior aspect of thigh. And superficial fascia শেষ. Deep fascia. Deep fascia is taut in elastic membrane of fibrous tissue which encloses the body deep to subcutaneous tissue like a tight slave. It keeps soft tissue in place. Mode of modification of deep fascia. The modification of deep fascia are as follows: retinaculi. At certain side, deep fascia thickens to form thick bands of retain the tendon of long muscle in place and prevent their bursting during action of this muscle. These bands are called retinacula. Example: flexor extensor reticula around the wrist and ankle joint. Epinosis in palms and soles in thickness of the form palmar and plantar epinosis to protect the underlying structure. In true sense, an epinosis is a thick white sheet of fibrous tissue that provide attachment to muscle. The palmar and the plantar epinosis represent the degenerated tendons of palmar longus and plantar muscle respectively. Fibrous sheath. At certain sites, deep fascia condenses to form a sheath around the neurovascular bundles. Carotid sheath enclosing common carotid artery, internal jugular vein and vagus nerve. Axillary sheath enclosing axillary artery, axillary vein. Deep fascia is dense around the artery and rather loose around the veins to allow the veins to distend. Fibrous capsules. At some sites, it splits to enclose certain glands to form their capsule. Example: parotid gland, submandibular gland, thyroid gland, etc. Interosseous, the forearm and leg, the deep fascia is modified to form the interosseous membranous. Intermuscular septa. In the limbs, deep fascia sends fibrous septa form it deep fascia to help from the compartment of the muscle. Fibrous flexor sheaths. On the flexor surface of the fibrous, the toes, deep fascia thicken to form the fibrous flexor sheath around the long flexor tendons. These sheaths prevents the tendons from browning out of position. Ligaments. The ligaments of the joint are considered as localized thickened bands of the deep fascia. Facial sheath. It forms fascial sheath. It forms sheath around the certain muscle psoas sheath. Clinical correlation. Since deep fascia defines fascial plans between the muscle, these plans from potential pathways for infection to separate. Path tends to force its way along the lines of least resistance provided by the plans of deep fascia. Paths can track down through the facial slabs from by the deep fascia around the blood vessel and muscle. Paths from root of neck can track down into the arm through axillary sheath. Paths from tubercular thoracic spine can track down in the inguinal region through the psoas sheath. Surgeon can operate Surgeon can operate along the fascial plans with minimal injury to the adjoining structure. Deep fascia is least marked scarcely demonstrable in the region of anterior abdominal wall is considered to be absent. Site where deep fascia is absent. Deep fascia is absent in the following site. Deep fascia কোথায় কোথায় নাই? Face আর breast.
Face আর
breast. Absent কোথায় কোথায়? তাহলে সুপারফিশিয়াল fascia ডিপ fascia, সেই ডিপ fascia আবার ফেস আর ব্রেস্টে নাই। তারপর হচ্ছে আরও আছে অ্যান্টেরিয়র অ্যাবডোমিনাল ওয়াল, প্যানিস এন্ড স্ক্রোটাম, ইস্টিওরেক্টাল ফাসা, 5 জায়গায়। তাহলে কোথায় কোথায়? ফেস, ব্রেস্ট, তারপর হচ্ছে anterior abdominal wall, penis and scrotum, ischiorectal fascia.
Ischiorectal মানে
The deep fascia. Deep fascia is very sensitive. Its nerve supply is derived from nerve supply overlapping spine. Nerve supply enclose the muscle. Function of the deep fascia. Function of deep fascia are as follows: keeps the underlying structure in position, preserves the characteristic surface contour, example limbs and neck, provides the extra surface for the muscular attachment, facilitates venous and lymphatic drainage, binds bone interosseous membranes, retains the long tendons in place to prevent their broad-string, and also serves its pulleys during their actions. তারপর হচ্ছে গোল্ডেন ফ্যাক্টস অফ রিমেম্বার. লার্জেস্ট অর্গান অফ দি বডি এরিয়া ওয়াইজ স্কিন. Largest sensory organ of the body is skin. Thickest skin of the body, palms of hand, soles of feet. Thinnest skin of the body, glands, penis, and eyelids, and eardrum. Commonest type of the skin cancer face. Commonest congenital disorder of skin is mole. Mole melanocyte nervi. Melanocyte clustered in high densities. Most common skin cancer, basal cell carcinoma. Largest modified gland of the skin, mammary gland. Modified sweat gland in female. Mammary gland হচ্ছে modified sweat gland. তার হচ্ছে fingerprints were first used in chemical investigation by Henry Folds in 1880. Henry Folds. তারপর exoskeleton human is represented by hair and nails. Largest sensory receptor skin is Pacinian corpuscles. Longest coarse hair in the body, hair on scalp. Smallest coarse hair in the body, eyelash of the lower eyelid. Naked apes is humans.
Naked apes.
Apes হচ্ছে humans. Naked apes কেন? Most common type of hair in the body is definitive or villous hair. Side with maximum number of the sweat glands, forehead, palm, soles. Side with maximum number of the sebaceous gland, scalp. Nail with fastest growth, nails of middle finger or of hand. Sides with abundant fat at superficial fascia, breast, buttocks, flanks, anterior abdominal wall, below the umbilicus. Sides where fat is absent, superficial fascia, eyelids, penis, scrotum. Most common tumor arising from subcutaneous tissue, lipoma. Ideal site of subcutaneous injection, posterior aspect of arm, anterior aspect of forearm, anterior abdominal wall, anterior aspect of thigh. Toughest deep fascia in the body, temporal fascia, fascia lata. Sites where deep fascia is absent, face, external genitalia. Thinnest deep fascia in the body, fascia of the graduate, deep fascia of the anterior abdominal wall. Multiple choice question.
All the following statements are true regarding skin except it D. Form about 27% of the body weight in adult. False. So the truths are forms a dynamic interface between the body and the external environment. Is the largest organ of the body, develops from both ectoderm and mesoderm. Epidermal layer not present in the skin is stratum lucidum. All of the following contribute to skin color except dermal papillae. Skin color except dermal papillae. Regarding cleavage, Langer lines, all of the following statements are true except their direction is vertical in chest and abdomen. Vertical না, সুতরাং ট্রুথ হচ্ছে they are caused by the pull of elastic and collagen fibers in the dermis. Incisions made parallel to these lines heal quickly and reduce hairline scar. Incisions made across the lines heal poorly and produce white thick hair. So B. Across these lines heal poorly, parallel to line heal quickly. Not true about apocrine sweat glands. All of the following statements are true except that they discharge their secretion always on the skin surface. Regarding dermis, all of the following statements are true except it develops from surface ectoderm. In which kind of burn is healing slow and leads to scarring? Third degree burn. Fat is absent in superficial fascia of anterior abdominal wall, below umbilicus. All of the following muscles are present in the superficial fossa except pectoralis major. All of the muscles are present in the superficial fossa except pectoralis major. All of the following are modifications of deep fascia except plas, platysma. So all of the modifications of deep fascia is axillary sheath, peritrachea fascia, retinacula.
Regarding this chapter, the student should be able to enumerate the types of skeleton, list the bones in each type, list the function of the bone, enumerate the different type of cell of bones, classifies the bone according to their shape and give an example of each. Describe the sesamoid bones and list their characteristic features. Outline the parts of the growing long bone and discuss the arterial supply. Describe intermembranous ossification. Describe intercartilaginous ossification. Compare and contrast the structure of compact and spongy bones. Classify different type of the cartilage and give an example of each. Describe the growth of the bone. Discuss remodeling of bone and clinical significance. Correctly solve the review question given at the end of the chapter. Introduction. The skeleton of the body is composed of bones and cartilage. Both bones and cartilage are made up of specialized connective tissue called the skeleton or tissue, which can bear weight without bending and has considerable tensile strength. The skeletal tissue consists of same components, cells matrix, as that of general connective tissue, but physically different from its that its matrix is solidified. The function of the skeletal system are as follows. Forms a rigid frame of the body, provides protection of viscera, brain, heart, lungs. Viscera হচ্ছে কি brain, heart, lung এগুলোকে viscera বলে. Body from external injury, provides leverage for body movement. Types of skeleton. For the connective tissue দেখছো? For the connective components of the study, the skeleton is divided into two types: axial skeleton, appendicular skeleton. Axial skeleton. The axial skeleton consists of bones and cartilage that lie close to the central axis of the body. It includes skull, auditory ossicles, hyoid bone, vertebral column, and rib cases. Skull. It consists of two sets of bones: the cranial bones that form the cranium and brain or brain case of the case, and the facial bones. Auditory ossicles. These are the three small bones present in each middle ear cavity. Hyoid bone. It is located above the larynx and below the lower jaw. Vertebral column, backbone. They consist of 33 vertebrae, 7 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 4 coccygeal. However, sacral vertebrae fuse to form the sacrum and coccygeal vertebrae fuse to form the coccyx. Thus, vertebral column consists of 26 individual or mobile bones. Rib cases. Rib case. It forms the bony and cartilaginous framework of the thorax. The bone forming the rib case includes the 12 pairs of ribs which associate costal cartilage and sternum. Breastbone. Appendicular skeleton. The appendicular skeleton is bilaterally symmetrical and compresses the bones of the upper and lower extremities of the bone girdle, which anchor these extremities with the axial skeleton. Thus, it includes bones of pectoral girdle, upper limb, pelvic girdle, lower limb. The pectoral girdle. It consists of the paired scapula, clavicles, and capitals. It is not a complete girdle as it attached only anteriorly. Bones of upper limb. Each upper limb consists of humerus within the arm and radius ulnar within the
Bones. The bones are the hardest structures which form the rigid framework of the body. Structurally, bone is a highly vascular, mineralized connective tissue consisting of cells and dense intercellular organs matrix, impregnated with inorganic salts. The organic material mainly consists of collagen fibers and forms one third of the bone. The provides resilience to the bone. It provides resilience to the bone. The inorganic material mainly consists of calcium phosphate and traces of other salts. It provides hardness and rigidity to the bone and makes it radiopaculate in X-ray films. The bone is an inert material as often thought of by some students, but it is a living structure. It is supplied by blood vessels, lymph vessels, and nerves. It has the power of regeneration and repair. In fact, bones have greater regenerative power than any other tissue of the body except blood. The bones are subject to diseases like any other tissue of the body. Clinical correlation bone health. The bone undergo atrophy, for example, become thinner and weaker if not used. For example, bones of a paralyzed limb atrophy. On the other hand, hypertrophy, for example, become thicker and stronger if subject to support and increased weight. Therefore, regular exercise is essential to maintain the health of the bones. Note well, the skeletal system of an adult human is composed of approximately 206 bones. At birth, the skeleton consists of approximately 270 bones. In adults, the number of bones decreases due to gradual fusion of separate bones. Functions of the bones. The following are the functions of bones. From rigid framework of the body to give it a shape and support. Provide surface for attachment of muscles, tendons, ligaments, etc. Serve as levers for muscles to bring about a movement, protect certain viscera, for example, brain, spinal cord, heart, lungs, liver, bladder, etc. Contain marrow, which is factory of blood vessels, for example, white blood cells, red blood cells, platelets. Storehouse of calcium and phosphorus. About 95% of the phosphorus within the body is deposited in the bones and the teeth. Some bones around the nose contain large cavities filled with air, paranasal air sinuses which affect the timbre of the voice. Numbers of skeletons: axial skeleton skull. Cranial bones 8, facial bones 14, hyoid 1, ear ossicles
20 মিনিট পরে
6, vertebral bones 26, rib cage, sternum 1, ribs 24, total 80, appendicular skeletons, clavicle 2, scapula 2, upper limb, humerus 2, ulna 2, radius 2, carpals 16, metacarpals 10, phalanges 28, pelvic hip girdle, hip bone 2, limber lower limbs, femur 2, fibula 2, tibia 2, patella 2, tarsals 14, tarsals 14, metatarsals 10, phalanges 28, total 226, total bones of axial bones 80, total bones of appendicular bones
226
226,
206 না 200
total bones of axial skeleton 80, total bones of appendicular skeleton 126, total bones of the body 206. Microscopic structures of the bones. The bone is a specialized connective tissue and consists of the following three components: cells, ground substances, and fibers.
The ground substance and fibers together from the intercellular substance or matrix which gets mineralized cells. The bone cells are three types: osteoblast, osteoclast, and osteocytes. Osteoblasts. The osteoblasts are derived from the pluripotent osteocongenerator cells located in the mesenchyma, periosteum, and endosteum. They secrete osteoid, which is unmineralized matrix consisting of proteoglycans, glycoproteins, and type 1 collagen fibers. For mineralization to occur, the fibroblast secretes the osteocalcin and alkaline phosphatase, which release the calcium and phosphate radicals from the substance containing them. In addition, the osteoblasts release the matrix vehicles, membrane-bound vehicles, which concern calcium and phosphate, and are the most important factors necessary for mineralization to occur. They undergo mitosis. They are the precursor cell of the osteocytes. The blood alkaline phosphate level can be monitored clinically to assess the osteogenesis during bone repair. Osteocytes are derived from osteoblasts. Once an osteoblast becomes surrounded by matrix, it becomes an osteocyte. Osteocytes are flattened cells with numerous cytoplasmic processes. They are located in spaces within matrix called the lacuna and canaliculi. Respectively, the cytoplasmic process of neighboring cells communicate by gap junction. The osteocytes, unlike osteoblasts, don't undergo mitosis. The canaliculi radiate from each lacuna and permit diffusion of the nutritive material. Thus, cells remain alive and calcified matrix maintain the bone by their balanced osteogenic and osteoclastic activity. They secrete the alkaline phosphate to maintain calcification. When bone cells die, the matrix is decalcified. Osteoclast. Osteoclasts are derived from the fusion of the uncommitted cell of the red bone marrow that are related to a type of white blood cell called the monocyte, similar to the formation of giant cell by the fusion of macrophage. They are large cells with the multiple nuclei. They help in resorption of the bone and play an important role in the bone remodeling. They reside in shallow depression of the bone called the Hauschilt's lacunae. They don't undergo the mitosis. Ground substance. It consists of following components: proteoglycans containing a side chain of glycosaminide glycans, specifically chlorine sulfate and keratin sulfate; glycoproteins such as the osteonectin or osteocalcin, a calcium binding protein. A mineral component include the hydroxide calcium phosphate crystals, citrate ions, and bicarbonate ion. Mineral component mainly consist of hydroxyapatite crystals of calcium phosphate are contribute to the hardness and rigidity of bone. Water or tissue fluid, which contributes to a low degree of bone hydration, 7%. Fibers, they are type 1 collagen fibers and provide tensile state of the bone. Classification of bones. Bones are usually classified in three ways: according to shape, according to structure, structural classification, according to development classification. The classification according to the shape. Depending on the size, shape, and bones are classified into following types: long bone, short bone, fat bone, irregular bone, pneumatic bones, sesamoid bone, accessory bones. 7টা। এখানে দেখো এই long bone, short those in which length exceed the breadth and thickness. বুঝছো, লংটা বেশি থাকে, breadth and thickness থেকে বেশি থাকে, তাকে long bone বলে। Long bones are two types: typical and miniature. Typical long bones, they have the following features: consist of three parts, are elongated tubular shaft, diaphysis, and two expanded ends, epiphysis. Contain medullary cavity filled with the bone marrow, ossified into cartilage, lie vertically in the body, are weighing bearing, are found in limbs, that act as levers for muscle. The example typical long bones are humerus, radius, ulna, femur, tibia, fibula. The cervical Clavicle is only long bone which lies horizontally, ossify mainly in membrane and does not contain medullary cavity. বুঝছো, একমাত্র ক্যাভিক্যালই হচ্ছে তোমার লং বোন ঠিক, কিন্তু এটা হরিজেন্টালি থাকে, আবার কোনো মেডুলারি ক্যাভিটি থাকে না। তারপর হচ্ছে মিনিয়েচার বা শর্ট লং বোন। These are much shorter in length and compared to typical long bones which are epiphyseal present in one end only. The example miniature long bone are metacarpals, metatarsal, phalanges. All the metacarpals and metatarsal have epiphyses at their distal and except first metacarpal and first metatarsal which have epiphyses at their proximal end. Short bone are small in size and usually cubital in shape, presenting six surfaces. These bones are found in wrist and foot. Carpal bone or tarsal bone by short bone. All the short bone ossified in the cartilage after birth, except talus, calcaneus, and cuvette, which start ossify before birth. ঠিক আছে, সবগুলাই হচ্ছে আফটার বার্থ এক্সেপ্ট ট্যালাস ক্যালকিনাস আর কিউইট। Flat bones are the flat and shallow plate-like bones. They form the boundaries of the certain body cavities, cranium, thoracic cavity. The example of flat bones include the bones forming cranial vault, frontal, parietal, occipital, etc. Bones forming thoracic case, scapular ribs, sternum. Irregular bones are highly irregular in shape, versa the hip bones, vertebra, bones forming base of skull. Pneumatic bones are very variety of irregular bones which contain air-filled cavity or cavities within them. These bones are mainly located around the nasal cavity. Versa the maxilla, frontal, sphenoid and ethmoid bones. There are filled cavities in these bones are called the paranasal air sinus. Paranasal air sinus not only make the skull light but as a resonance to the voice. They also act as air conditioning chamber for the inspired air. Sesamoid bone. Sesamoid means seed. Are seed-like bony nodules which develop in the certain muscle tendons where দেখো sesamoid bone হচ্ছে seed-like bone বিচির মতো. The bone are nodules which develop in certain muscle tendons where they rub against convex bony surface during the movements of the joint. The rubbing surface of the sesamoid bone is covered with the articular cartilage. Site of sesamoid bones: patella in the tendon of quadriceps femoris in front of the knee joint. Flavella in the lateral head of the gastrocalcaneus behind the knee joint. Two sesamoid bones below the head of the first metatarsal bones in the tendon of the flexor hallucis brevis. One sesamoid bone is tendon of the perineus longus where it binds around the cuboid bone. Pisiform in the tendon of the flexor carpi ulnaris. One sesamoid bone in the ulnar side of the head is metacarpal bone in the tendon of the abductor pollicis. Sometimes a sesamoid bone is found in the radial side of the head, first metacarpal in the tendon of the flexor pollicis brevis. Function of sesamoid: act as pulleys for muscle contraction. Alter the
Acts as pulleys for muscle contraction, alters the direction of the pull of the muscle, minimize the friction of tendon against the bone to prevent its attrition. Characteristics of sigmoid bones develop in the tendons for the muscles are devoid of periosteum, ossify after birth usually by multiple contours, lack Haversian system. For note well, patella is the largest sesamoid bone in the body and the cartilage covering its articular surface is the thickest articular cartilage in the body. Sesamoid bones are not classified as true bones as they are not covered by periosteum. Accessory bones: these are bones that are not generally present in the body. If present, they do not cause any harm. Sometimes clinicians confuse it with a fractured bone. Accessory bones may be formed due to appearance of extra ossification centers in the skull structures. For example, sutural or vernier bones. Non-fusion of epiphyses. The examples are astrigonium, the posterior tubercle of the talus that fails to fuse with the rest of the bone; os vessalinum, the styloid process of the fifth metatarsal that fails to fuse with the rest of the bone; patella cubiti. Occasionally, the center of ossification for the olecranon process of ulna fails to fuse to proximal end of the shaft. For well, heterotropic bones sometimes form in soft tissues when they are not normally found. For example, rider's bones in a tendon of abductor longus muscle of the thigh. B. Structural classification microscopically. For example, as seen in naked eye examination of a section of the long flat bone, the architecture of bone may be compact, dense, or calcaneous spongy. Most bones of the body have a basic structure of an outer region of compact bone and inner region of spongy calcaneous bone. For example, in long bones, most bones of the body have a basic structure, an outer region of the compact bone and inner region of the spongy cancellous bone. For example, in longer bone and in flat bone. Note well, all the bones of the body consist of both compact and spongy bones except inferior nasal concha, which consists of only spongy bone.